We'll continue from where we stopped previously in our surgical OSCE. So we've done this, okay, this is where we stopped last time. Okay, again, today's OSCE session, again, going to be purely interactive. You and I will be communicating. You will do most of the answering, the discussion, while we're doing more of a guidance. Can someone answer this question? We've done this before, but let's just start from this particular point. Can someone give us an answer to this question? Can someone attempt answering this question?
Actually, sir, I'm not good at counseling, so I think it would be helpful for us if you help us with the counseling. Because actually, I'm not good at counseling.
Yes, I just want to see what you have. Eventually we'll talk about it. There's no harm in attempting to get.
Okay. There is a mnemonic called GADA we use in counseling. I'll use it to try and attempt this question. So I'll start by greeting. Good morning, ma. My name is Murtala Shehu. I'm a candidate of this examination. And for the purpose of this examination, I'm asked to counsel you about your condition. How proceed?
Yes, we can.
Okay. Good evening, sir. Good evening, ma. You are so diseased. Okay, you have been diagnosed with ductal carcinoma in situ. Can I ask you what you know about this condition? Do you know anything about this condition? Okay, I'll tell you more about it. So, ductal carcinoma in situ is a type of breast cancer. It's a type of breast cancer that you usually see okay, it's a type of breast cancer that usually happen in sorry, sir. I think I don't know where to go again.
Okay, you're done. Okay, are you done? Okay, now let me.
Yes, sir.
We've attempted this question. So if you go to the YouTube, you get exactly the answer to this question. It was in the YouTube video we dropped there. One of those surgicals, I think one of them, it's well documented there and you kept it there for your reference. Now, if you are to attempt counseling, be it, now there are two things about counseling. One involves breaking bad news, one involves consent taking. And this is breaking bad news. They are almost the same, just that they are most likely different. Now, the first thing you want to ensure if you want to break bad news is that you want to ensure that the environment is secured. The next thing you want to ensure is how receptive is the patient wanting to take the information. Then you want to know how the information the patient, what level of information the patient know. Then you start delivering your message. While delivering the message, you want to be sure that the patient is interested and he wants more and the patient understands. Having done that, you want to ensure that the patient is able to get to his or her final destination safely. And you want to book a next appointment. So these are the sequence you'll follow if you are to break bad news. Again, like I told you before, this thing was well dealt with. I think one of the OSCE videos you will see there. I think Dr. Shukura did that. She answered the question, so you could actually watch that video. But I'm going to give you the same answer now. Now, the question is: a 50-year-old housewife presented to your clinic with mammography showing features consistent with ductal carcinoma in situ in the outer half of the right breast. You have taken adequate clinical history and performed clinical examination of the breast, which are remarkable. Counsel this patient. So this is breaking bad news. Now, let me tell you, how do you know breaking bad? How do I identify a question of breaking bad news in the exam? Most times it comes with cancer. The question most times actually cancers. Question relating to cancers are usually breaking bad news. That's how you identify them. Or something relating to infertility. But commonly, breaking bad news is identified commonly by questions relating to cancers. When you see questions relating to cancer, you know this is breaking bad news. And how do you identify questions relating to consent? It involves either a procedure or surgery. So when you see something like take a so and so we want to go for surgery, counsel the patient, that is obtaining from consent, or need to pass a catheter, counsel the patient, that's consent taking. When you see something that involves story that involves cancer, that's breaking bad news. Or infertility, that's breaking bad news. So this question is attempting to test your knowledge about the ability to break bad news. So the first thing is to introduce yourself. I am Dr. Mortala. I'm a candidate of this exam and have some information to discuss with you. I have some information which is not too good to discuss with you. But before I go ahead, may I know your name? She will tell you your name. She's her name, okay? Like I told you, you want to secure your environment before you start. Are you comfortable if we have this conversation in this place? Or you want us to have this conversation in my office? To tell you that's securing your environment. Next, you want to ask, do you want someone else to be with you, or you're comfortable having this discussion alone? That's securing the environment. She will tell you, or he will tell you, okay, you can give me, I can take the news. Then there's usually, sometimes I don't forget, I usually bring this part, which usually in the last part, I usually bring it early so I don't forget, which is ensuring the patient movement to his our final destination is secured. I usually will bring this first. I usually bring it at this point, and so I don't forget. But usually at the last part of it. Then you then ask, do you have any means of going home, or should I make arrangements for you to go home? We'll tell you, okay, I have, or you don't have to bother, or I have my car here, my driver is around, something like that. That will be the response. The next you want to ask is, Ma, what do you understand by ductal carcinoma in situ? She will tell you, they're going to ask, okay, I'm afraid I have some not too good news to share to you. The mammographic findings from the mammography that was done shows features consistent with that ductal carcinoma in situ in the outer half of the right breast. However, we have examined you, we have taken history from you, and those history are not consistent with ductal carcinoma in situ. I don't want to hear that. I'm not primarily testing your knowledge about ductal carcinoma. That's not the primary aim here. Primary aim is how you're able to break bad news, so you should understand what the question tells you about. Okay, after having said this, okay, you don't ask her again. Like I told you, you must periodically assess your patient whether they are wanting to want more. Do you want me to tell you more about this condition, about our findings? You must ask her. She will tell you, okay, fine, I want more. Okay, now explain. Total carcinoma in situ, it's a pre-malignant state. Sorry, it's an early malignant state, which demonstrates that there's some malignant transformation in the breast, but this tumor has not started spreading beyond the lumen of the, so beyond the epithelial lining of the breast tissue. That is what the mammography findings showed. However, from the history and examination, it did not reveal anything significant. This may be so because sometimes ductal carcinoma in situ may not be clinically palpable in some cases. Are you comfortable if I give you more information? Who said yes. Next will be, having had this diagnostic dilemma, it will be advised that some other means of investigation may be required, and this may include a breast biopsy. And the essence of this biopsy is to take tissue from the breast, and especially from this right outer quadrant of the breast. And because it is ductal carcinoma in situ, there are multiple options of breast biopsy that can be adopted. We could have the guided biopsy, which can be ultrasound guided biopsy. We could have the fine needle aspiration cytology and biopsy. We could have the open biopsy. These are the options of biopsy for this patient. For that can be adopted for this case. The benefit of ultrasound guided biopsy is that it can help us locate lesions in the breast, and therefore one can have a localized, more specific biopsy. The other, which is the true cut biopsy, which is the open biopsy, one can do a true cut biopsy where one can take multiple true cuts. Then one can do an open biopsy. So we're able to take tissue. And when the tissue are taken, tissues are sent for histology and immunohistochemistry. In the histology, whatever is the findings will help us whatever is the finding, it will help us. So, okay. Hello, can you hear me? Can you all hear me?
Yes, sir. Yes, sir, we can hear you.
Okay, fine. From the histology, we could be able to tell if the nature of the disease, and therefore appropriate treatment may be carried out at that point in time. Might you want more information? Well, She will say, are you comfortable with getting more information? She may say yes, she may say no. But having said this, it's very essential that I will let you know that Dr. Carcinoma Institute, or be it in the words from the breast cancer, is not a death sentence. Statistics, you then quote statistics, you mustn't know anything, you can just quote something. That those that come early, especially if it is the Dr. Carcinoma Institute, their survival rate is about 96% for about 80 to 96% over a period of 5 years. Those that occur from that come at stage 2, usually within 60 to 80%. Those that occur at stage 3 is usually within 20 and 40%. And those that occur at stage 4 usually within 1 and 4 to 6%. However, for this Dr. Carcinoma Institute, they are at the early stage, so survival is very, very high. So you don't have to be afraid. Then at this point, you can then bring your local experience. We've managed 57 patients in the period of, or we could also manage like 200 patients in the period of last 5 years. And of these 200 patients we managed, 198 of them are still alive. And we'll form a breast cancer club, which periodically they all participate and share knowledge and experiences among themselves. Do you want more information? Yes. Let me, at this point, I missed something, so I want to bring it in now. Let me introduce the members of the team to you. My immediate senior is Professor Aliyu. He's the head of the unit. I'm a member of the team. Other members of the team include Dr. You could call anybody Dr. Patrick and Dr. maybe Ferdinand. Do you have any questions you want to ask me? Okay, are you sure of what the conversation we've had? Could you tell me what I've told you so far? We should just give you a summary. Okay, thank you very much. Do you have any questions you want to tell me, you want to ask me? She may say no. At this point in time, that's okay. Do you have any means of going home? Said yes. Should I make arrangement for you? Which this when it comes in, but I've done that early, so I don't forget. Do you have any means of going home, or should I make arrangement for you to take you home? So you may say yes or no. Okay. Then the next ask her that tell her that our clinic days are usually on the you could quote on any day. Tuesdays are usually once weekly, start from 8 o'clock, ends by 12 o'clock or ends by 4 o'clock. They're always present. You need time to think about all we have said. You may say yes. Okay. Once you have made up your mind, you could always come to our clinic in any of our clinic days, or you could maybe give me a call if you have your number. That's okay. Thank you very much. Is there any question anybody want to ask me? Are we okay? Hello?
Yes,
Am I
sir.
communicating,
Yes, sir.
or I'm talking to myself?
No, we can hear you, sir.
Okay.
The question I want to ask is that they said it's usually 5 minutes, and
Huh?
do you have all the time to explain all these things to her?
I'm trying to reply to someone that sent message.
Okay, sir.
Sorry, I'm trying to reply to someone that have been calling me.
Sir?
I'm trying to reply to someone that was calling me. I'm trying to send a message to someone that have been calling me. Okay, so what was the question, please?
Okay, the question, sir, is that they said you usually have 5 minutes to counsel the patient. Do you have all the time to explain all these things?
Hold on, sorry, please. She better be. She better be. She better be. Shifetubi. Shifetubi. Shifetubi, can you hear me? Shifetubi, can you hear me? Please, once you are ready, please, I can let you speak. I can let you, I can hear you. I can let you continue. Otherwise, hello. Okay, I saw your message now. Please, no problem. We can reschedule your presentation tomorrow. Yeah, if you can hear me. Okay, thanks. I appreciate so much. Thanks. Okay, so Dr. Tubi's lecture, community medicine, will take place tomorrow by 7 o'clock. She was around. I didn't even know she was around. So while I was giving this lecture, sorry that I didn't recognize your presence. I'm very sorry, but I didn't see you. I didn't see that you were around. So her lecture will be tomorrow by 7 p.m. Okay, so can we continue? Okay.
Yes, sir.
Okay, so what was your question again, sorry?
I said that they said we have 5 minutes to counsel the patient. My question is that
Okay,
how can we
Dr.
manage
Tubi
this
said
5
I should
minutes
send her regards to all of you.
Okay,
Okay,
we
I'll continue.
appreciate it. Yeah.
Thank you, Doctor.
Thank you. Yeah. Thank you, Doctor.
Okay, so what is your question, sorry?
Okay, my question is that we have 5 minutes to counsel this patient. So how can we manage the time to explain all this that you explained to us right now? Because
Okay.
I see that it's too much to discuss in 5 minutes.
Okay, let me tell you how you go about it. One, first of all, it's practice first. One, when you practice, again, you don't need to cram this stuff. You just need to understand the steps that you follow. And when you follow the steps, again, you don't need to dwell in the clinical aspect. I'm able to dwell in the clinical aspect because I have some knowledge. What they want to hear in this your clinical aspect is biopsy. And once you say the biopsy, they are okay. Whatever you say in biopsy, it's not their business. Okay, that's number one. But again, I said practice. Follow the steps and you will not be wrong. Then for exam, let me give my experience. When you have too much information, you must. One of the problems you will have with your examiners is that they easily lose attention. So maybe sleeping, maybe not even be hearing you. So first thing first, you must be audible, very audible, not shouting. Don't I don't mean shout at the top of your voice, so, but you must be audible enough for them to hear you. And you must have a command of English and attention, so that when they not arrogance, the difference between arrogance and command of attention. So by the time you enter the venue and you are talking, not shouting in a loud voice, but not shouting, so that you are not making noise, you can keep their attention. Once you're able to keep their attention, again, no, the problem with us kids is that sometimes these people will not hear you, will see it and they will not mark you. So if I'm to give this is good afternoon, ma. Good afternoon, sir. Okay, thank you. Good afternoon, ma'am. My name is Dr. Isaac Opako. I'm a candidate for this exam. May I know your name? Thank you very much. Sorry, ma, I have not too good news to share with you. Please, ma, may I know if you are comfortable having this conversation here or you want also have it in your office? Please, ma, are you comfortable having this conversation alone or you need someone around you? Yes. Please, mommy, I know what you understand or know about Dr. Carcinoma Institute. All this now I've said is less than 30 seconds, so let's say 1 minute now. So what you should what I was why it was long for me was because I was taking it slowly so that you could get it. I wasn't putting it in exam mode. I was just making it slowly and calmly so that you could pick the points as we go along. So again, like I said, it's practice. And when you practice this thing, it becomes a part of you. The steps again, there's this guide, there's no you say gather fine, but I usually prefer to use the steps. The steps that you must secure your environment. How do you secure your environment? By ensuring that the patient is safe. How do you ensure the patient is safe? By ensuring that the patient is comfortable to have the conversation where you are, or in somewhere different. Whether patient prefer someone to be with them or she or she wants the conversation alone. So secure the environment. You want to assess the patient knowledge by asking question, what do you know about the conversation? But the condition, then you break the bad news bit by bit. Periodically, always ask the patient, do you want more information? Please, as you go along, as you go along, as you go along. At point in time, you can bring in, so bring that. I just prefer beginning. You can actually introduce member of the team, but most times it's best to introduce a member of the team when you start getting to your clinical condition. But sometimes it's best to introduce a member of the team at the beginning so that you don't miss it. So we bad news. Then the next thing you want to do is make sure that the patient understand what you ask by asking the patient, what have I said? Then ask the patient have any question. Then ensure the patient is able to get to his final destination by asking, do you have a means of going? What should I make more available for you? Then ensure the patient can come back to you by telling the patient, do you, my clinic this and so and so. If you need time to think about it, I can let you, you could go home, and when you made up your mind, you could come back. My clinic is so and so and so. So in those instances, you'll be able to then thank the patient. You've done that. Just the sequence that is most important. Are we okay?
Yes, sir.
So we can move to the next question, Abby.
Okay.
Is anybody having any query?